Welcome to MedAxiom HeartTalk, where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, host of MedAxiom HeartTalk, and today we are delving into an important and evolving area of patient care: how cardiology and emergency medicine teams are coming together to transform cardiovascular care. And I am joined by two leaders in this space. We have Dr. David Wohns, an interventional cardiologist and division chief of cardiology at Corewell Health, and then also Dr. Meredith Busman, emergency physician at Emergency Care Specialist, Corewell Health as well. So thank you all for joining us today.
Thank you.
So to begin, I would love for you all to share really what inspired you to focus on improving this collaboration between emergency medicine and cardiology.
Well, I'd say if we go back years ago, often conflict as opposed to collaboration, and memes that would go around about, ER docs and cardiologists clashing over the care of patients as they come into the emergency department. That's no fun, having conflict about that, and we're really kind of all trying to get to the same end. So, it's much more fun when you have trust and collaboration and partnership in taking care of patients.
Right.
And so that prompted us to really kind of engage, on both sides, but from the cardiology standpoint, to engage with our emergency medicine doctors and, get them very involved in our programs.
Yeah, really problem solving, it sounds like. Yeah. Meredith, what about you?
Well, and to build off that, I would say that there's really no other option. I mean, there are certain specialties I, as an emergency physician, can't do without, and probably at the top of that is cardiology. My job is to treat, triage, and disposition patients, and if I have a patient who comes in with a heart attack, besides giving aspirin, there's very little else I can do. I need cardiology in my corner, and frankly, I don't have time to waste having a discussion over the phone. We need to have a trusting, collaborative relationship so we can get patients the best quality care as soon as possible. Especially with how busy our emergency departments and hospitals are getting. We're seeing more and more patients all the time. We need to have that efficient communication.
And I think patients expect that, especially when they're coming in and they think it's their heart. They always think they're prioritized, and they are, but that collaboration is so important for that end outcome.
I'd say there's always a lot of fear when patients come in, with symptoms of chest pain. There's a lot of uncertainty around that.
And just to add to that, I mean, this is very time sensitive, treating these patients and diagnosing them and so on. So without this partnership, we could not achieve those goals. And we know kind of time is muscle, for example, with heart attacks. And so rather than waiting till the cardiologist called back to the ER doc, talk to them and so on, we just fully empowered and trusted our ED docs to take care of those first steps that these patients need.
It sounds like something fundamentally needed, what you all are doing, but did you find any barriers when you first started this partnership?
I think the early barriers were, in my mind, sort of two things. One is building trust with one another. Not that there was major mistrust, but kind of full trust so that we could empower one another in the care of these patients. And in some ways it was cardiologists giving up some of the things that they were kind of micromanaging in a way that were very much in the domain of our emergency medicine doctors. So, so trust, and then time. Just this is, and a leader that's passionate about this. So, this change management in terms of how we take care of these patients, you really needed the time to do that, and build the relationships, to build trust, and then put algorithms and protocols together that we can work on together.
And then it comes back to, how do you build trust? It's the same way that you build any relationship, is you take it off the phone, take it offline, and you put it in person. So it's getting emergency physicians and cardiologists together in the same room, on the same committee. And so you're not waiting to have those conversations over the phone in the heat of the moment. You're having them in a separate space where you can come to know each other and really see the person on the other side. And that goes so far towards building that trust and really respecting each other's knowledge as a specialist in the space.
Yeah, you guys seem to kind of have a good rhythm going. How long did that take you for you all to kind of figure that out? Oh, I can lean on her and I can lean on him and we've got this together.
Yeah, well, I'll say, I've been fortunate. I've always had such a good relationship with the cardiology team at Corewell. It's been a given that I, can trust them, but that's taken a lot of work by a lot of physicians who came before me. And so I'm just looking to continue building on that.
Yeah, I love that. All right, so let's talk about shared pathways and streamlined communication. Can you really break down what those terms mean in real world practice? Also in these high stakes situations that you mentioned, when patients come in the emergency room and they need that care immediately.
Yeah, no, that's a really good question. So in the emergency department, we have constant distractions and interruptions. It's read this ECG, take this phone call, STEMI code, stroke code, trauma code. And so when I'm caring for a patient and I'm trying to make a critical decision with high diagnostic accuracy, I need some fallbacks. I need some ways to kind of cognitively offload some of that critical decision making. And so when you have a streamlined protocol that's easily accessible and easy to follow, that is so helpful, where I can take my patient coming in with new onset atrial fibrillation, for instance. I can access that protocol and all of a sudden I know which medications I'm giving them. I know, what my process is for follow-up, when I need to consult, when I should consider hospitalization, and when it's safe to discharge home. That is really important towards getting that patient that efficient care, and meaning that we have all of the communication that would normally go on for that patient was done ahead of time. That consult was already done when we developed that protocol.
Yeah, what are your thoughts on that? It sounds like that.
I've been at this a few more years than Meredith has been, and kind of lived through some of these changes. And I look back, probably one of the first pivotal change was the STEMI patient, the heart attack patient, where time is muscle and we need protocols to make this an efficient enterprise. And so that's now been great, and we've worked on that for a while, but we've created similar kinds of pathways and protocols that we collaborate on as we build them. What's appropriate to do in the ER, what's appropriate to put somebody in observation, who should be admitted. And just a couple examples of where we've done that recently is our diuresis protocols for heart failure patients. So education with our ED docs, some consensus amongst what they can do, what we can do, who needs to be admitted, who doesn't need to be admitted, and just earlier treatment. And that's actually reduced our lengths of stay, as well as reduced our hospital admissions, for example, for heart failure. Kind of one example, and another kind of big example of the same thing is management of atrial fibrillation. Pretty dramatic story. I don't know, would you like to comment on that?
Yeah, well, historically, atrial fibrillation has been a condition that a lot of patients are admitted for, sometimes in the hospital for a couple days, and require fairly intense care to get them started on medications. We came up with a pathway that got patients started on those medications right out of the emergency department, providing important therapies such as electrical cardioversion when appropriate right out of the emergency department, and then even implementing a one-click scheduling follow-up where the emergency provider can schedule a follow-up appointment within the next week with a cardiologist at multiple offices, making it easy for patients before that patient ever leaves the emergency department. So we've seen our numbers of admissions for patients with this condition really plummet. And while still ensuring excellent patient care, it's been a real benefit to the system, and I think patients appreciate it as well.
And you talked about earlier how it's a time when patients are scared, and so to be able to kind of have something in place that allows for that accountability for them and the follow-up, it really does work.
Yeah, I mean, historically, we would probably get called for almost every one of those patients who comes to the ER with atrial fibrillation years ago. Now, I think probably it's maybe 1/3 of those patients that require any phone call. It's protocolized, agreed upon, and easy to execute on.
Right. Well, that's great. Yeah. So observation medicine, you did mention that. It does play a key role in this approach. So how have you seen it impact not only patient outcomes, but also hospital efficiency and clinician workflow as well?
When they come in with atrial fib or, congestive heart failure, we need to follow these protocols. We watch them for a period of time. I think it's less than 12 to 48 hours. And so the patient can then declare themselves for troponins, for example, for tracking that. Is it going up? Is it going down? Is their oxygenation improving? Are they diuresing? time to observe what the trajectory of the patient is to determine whether they need an inpatient stay or can be safely sent home.
Mm-hmm. So if you're listening and you're like, this is great, you know, this clearly works. What are one or two things that systems can really do to get the ball rolling to make this type of collaboration happen?
You know, I think it goes back to finding ways to kind of build trust first, because if you don't have trust, then you can have all the pathways and all the protocols you want, people aren't going to follow them. So you need to create a space where the two teams can get together and can work to develop pathways that both sides agree on and that are going to work to address the different problems that the emergency department and the cardiology teams are looking to solve. So I would say it's, you know, getting out of the department and it's sitting down and it's saying, what are our goals here and how do we achieve them together?
Yeah.
Yeah, it's trust, it's relationships that you build in with that trust, and then it's the time to interact as Meredith has just kind of outlined, and it's to get a champion for whatever this happens to be. You know, for example, with our relationship with the emergency department, we have a doc that from the emergency department that regularly meets with the cardiologists, comes to our division meetings, comes to our section meetings, brings back data, reports out on a regular basis. And that's how you kind of continue to build that relationship and look for new opportunities of efficiencies that we can do together.
Yeah. Do you think this works in every hospital? You think it could, or are certain ones more prime for this?
Well, I think it needs to.
Yeah.
You know, medicine is only going to, grow more complex as our patients get sicker and have more complex conditions. I think that this needs to be an area of focus for, any, large hospital, certainly that's going to deal with these cardiac patients.
We just had a new initiative in measuring lactate in patients that come in with STEMIs. It can be an early marker and help us determine is somebody sicker than they may look and to be able to follow their trajectory. So I called my colleague from the ED, talked about putting that into our protocol, and with, like that was in the protocol. We announced it to everybody.
Wow.
Total trust. Some education associated with that, and that's something we just did, in the last couple of months.
I was going to ask about how this could evolve. So it's a living, breathing protocol that can change.
Yeah.
Yeah, awesome. I love it. Oh, thank you. And I appreciate the examples. That makes it real. Well, thank you both for coming in and talking with us on this Heart Talk.